Hello, everybody. Thank you for joining us. We're going to get this afternoon's or this morning's webinar underway, depending on where you are in the world. Thank you very much for being here. It's been a slightly longer break than usual and than we would have wanted, but we are back underway with our World Federation webinars, and we hope that you'll be able to join us more regularly moving forward. Before we get underway with the session, I just want to do a little bit of housekeeping so that the session runs smoothly. Please feel free to introduce yourself in the chat box down below. It's always great to see where you're all working, where you are in the world, and where you're joining us from. We have got a truly international audience for this session today. If you have questions for our panel, please post them specifically in the Q&A box, which is highlighted there on the picture. We can then filter them and look at which of the questions are most popular, and we will take them in popularity order at the end of the session. Please complete the post-webinar survey. You'll be directed to that automatically. Your feedback's really important to us because it helps us to make sure the events that we put on in the future are what you're looking for in terms of your CPD and education. We will send out certificates to those of you that are joining us in this session live, and we will send out a link to the recording, which will be on our YouTube channel. You'll get all of those automatically, and they should go out within 24 hours. If you do email me before that, there is a chance that I will ignore it. I'm very sorry. It's my pleasure to pass you over to the World Federation President now, Brian Zeller, who's going to get us underway with this afternoon's session. Brian.
Great. Thank you, Ollie. I really appreciate it. I do want to make sure I thank the British Association of Sports Rehabilitators and Ollie for helping us host this session. We're excited to get these webinars back up and going, and we're looking forward to having a number of them, not only for our academic institution members and academic educator friends, but also for clinicians out there that are looking for global content. We're looking forward to doing those more and more in the future. So please look out for social media. If you don't like us on social media, please do, and you'll be able to get some of those announcements that we have. So as Ollie mentioned, I'm Brian Zeller. I'm the chair or the president of the World Federation of Athletic Training and Therapy, and I wanted to welcome you to this session. I want to thank Hannah and Josh for their time today. I appreciate it. And please do fill out that survey for us so we know exactly what we can try to offer in the future. So enjoy your day, your morning, your afternoon, wherever it might be. And thank you again. Ollie.
Thank you very much, Brian. Yes, and thank you everyone for joining us and taking this time. So as Brian's kind of alluded to, this is our first webinar of the year and something that we hope to continue moving forwards and hope to at least host one quarterly. So this one's brought to you by the academic institution of WFATT, which I'm the chair of. And today we're going to discuss a topic of conversation that certainly is very new and interesting to myself from a personal standpoint, something that I'm slowly starting to get to grips with, which will introduce us to the different types of simulation that can be used for educational purposes. So we've got two really good speakers lined up for you today, and I hope you will enjoy it as much as I have. So before we get started, I'll just do a brief introduction to them. So we have Josh Larson from the University of Utah. He is the practical and simulation manager and teaches acute care and simulation for athletic training. Josh is also a part-time paramedic, EMS instructor, campus coordinator for the Pac-12 Health Analytics Program, and PhD student in rehabilitation sciences. Josh is doing it all. His current research interest revolves around pre-hospital care and its impact on the continuum of healthcare and long-term outcomes for patients. Currently, he is researching pre-hospital falls and medications used in pre-hospital births. We're also very fortunate to be joined by Hannah. Hannah is a certified athletic trainer and instructor of athletic training at Weber State University. Hannah teaches for the program of athletic training and masters of athletic training. She's also a PhD candidate at Rocky Mountain University of Health Professions with a concentration in athletic training. Hannah has over 14 years of experience as an athletic trainer and 10 years of teaching experience. Her speciality lies in rehabilitation of orthopedic injuries. And yeah, I'll hand it over to those two now who will lead it with you, and then we'll come back at the end for some Q&A. So please do post your questions as we go through so we can rank those and save them for the end. And I'll see you guys then. Thank you. Hannah and Josh, over to you.
Hello, everyone. Thank you so much for joining us today for a little bit of a presentation on the use of simulation in health professions education. Thank you so much, Ollie, for that great introduction. My name is Hannah Stedge, and I'm happy to be joined by Josh Larson today as we kind of share our experiences through trial and error about some great tips that we have for using simulation in your educational program. Before we get started today, I wanted to introduce to you our learning objectives for this webinar. By the end of our webinar today, we hope to have you be able to identify the different types of simulation that you can use in your education program. We hope that you are able to determine which type of simulation is beneficial for each of you, depending on your particular setting, and to be able to describe the practical implementation of using simulations in your health profession curriculum.
So real briefly, what is a simulation? A simulation is like any other teaching tool or strategy to promote learning, skill acquisition, or experience. So basically, a simulation is just another teaching tool like anything else we might use.
As we get into today, we wanted to kind of define a few terms that we're going to be using so that you can kind of have an understanding of where we are and hopefully eliminate some of the questions that you have right off the bat. So when we talk about simulation, there's a few different kind of levels that we can talk about and that we can utilize in our programs. So much of the information that we are referring to today comes from the INOXL Best Standards of Practice for Designing Simulations. And so those are going to be some articles that you'll receive after this webinar that you can refer to later as you start to design your own simulations. So when we talk about simulation, first of all, we have to consider the level of physical fidelity in the simulation. And so fidelity is really simply the amount of realism that simulation can provide. Essentially, the theory is the higher the fidelity, the more realistic that simulation could provide to your learners. So the lowest level of fidelity would be through the use of task trainers, or at least physical fidelity. So that being you have physical equipment that you're using to help simulate this. So a task trainer would be potentially a partial body model, or it could be as simple as like an EpiPen trainer. These are fairly inexpensive, and they're commonly used for training your learners on emergency care skills and physical examination skills. The next level would be through the use of standardized patients, which are live persons who are trained to portray a specific case consistently over time through multiple learners. Standardized patients typically will charge for each student encounter, or if the procedure is a little bit more invasive, they may also charge per procedure that is performed on them. Depending on what the encounter is, they may charge between $30 and $100. Standardized patients are often used to teach and assess clinical skills, so they may be an assessor of your learners' clinical skills. They're very beneficial for improving interpersonal skills, as well as providing your learners some immediate feedback on their skills. And they're also helpful for building students' self-confidence. And then high fidelity simulation would be utilized through an instructor-controlled computerized mannequin. These obviously have a large upfront cost because they're a large piece of equipment that can perform multiple different things. They're especially useful because they can portray abnormal heart-lung bowel sounds. And so they're used mostly for helping students with their critical thinking skills, obviously emergency care assessment, and then they're great for helping students to make those on-the-spot emergency decisions that otherwise they would have to do in real life the first time they see a patient. Some other aspects of the fidelity to consider are the conceptual fidelity and psychological fidelity. So having physical fidelity is great. Having that live person or that high fidelity mannequin is really helpful for kind of putting the student in that alternate reality setting. Along with that, you also want to think about the conceptual aspect. So trying to make it conceptually as real as possible. So does this simulation make sense? Some ways that you can do that are by having that environment set up so that it looks like the environment you're trying to simulate. So if you're trying to simulate an emergency on a sport field outdoors, you could consider having your simulation outdoors. That makes it a little bit more challenging, but it would be a little bit more of a realistic environment for the students. Some other ways you can do conceptual fidelity are simply by getting the students kind of in the mentality of a patient interviewer. So you could have them do some student role-playing cases. That's really commonly used in a classroom setting. I'll often do that, as a portion of my lecture or discussion for the day. I'll present a case kind of similar to this one right here that we have. And so I'll present either part of that case or all of it. We typically will do like an interrupted case. So I'll present them kind of that first sentence, and then the students have to ask questions to figure out the rest of the information in that case. This is really great for getting students into that problem solving, kind of getting that investigator hat on. And then lastly is psychological fidelity. So this one takes a little bit of we'll get into this later, but of pre-briefing the students, getting them to understand and imagine that they're in that alternate environment. And it also involves an emotional component. So a lot of the simulations that we tend to do, we want to kind of trigger that emotional component so that the students kind of realizes how important this situation, this may be a life-threatening situation, or it's really essential for them to understand how to do before they interact with an actual patient. So next, we wanted to provide a brief history of simulation in education, so you can kind of see where we came from and where we are now. So simulation actually began its roots in the military and the aviator field. So in 1928, the very first aviator simulation began, and it was by Edwin Link, and he built that first aviator simulator called the Blue Box. From there, the military kind of began using simulation in their trainings, and they still are today. They're kind of the leader in simulating emergency situations. In 1960, Lyerdale Medical developed their first simulator called the Resusci Annie. The 1990s was really when medical programs in the US began introducing some high fidelity simulation. And this was mostly in nursing programs and other medical programs. And then in the year 2000, Lyerdale Medical beta tested their SimMan 3G. And that is one of the common high fidelity simulator mannequins that is still on the market today. So Josh is going to talk about each of these integral components for building your simulation encounter, but I wanted to introduce them here first. So there's really 5 components that we feel are really essential for you to include when you're designing your encounter, and it's also backed by the INOXL Standards Committee as well. So the first component is figuring out your purpose or your goal for this learning experience for your students. Then preparing your students with materials or resources in advance that are relating to that topic that they're going to be doing the simulation on. Next, it's important to pre-brief the students on what they should expect out of this encounter. And then we'd like to encourage you to act as a facilitator or have others act as facilitators throughout the encounter to ensure that safety during their learning experience. And then lastly, this is really the key component here, is having that structured debrief to help the students kind of solidify their learning and rethink what happened and be able to make changes to go forward in the future.
Great, thanks, Hannah. So, our biggest thing, our first thing to decide really is what the purpose or goal of this experience is. So if it's summative, that means it's just a test. And certainly that has its place in simulation, but it probably isn't the one we're going to use the most. Formative is really probably the one we may choose to use the most. And that's where, we're giving them an experience, we're exposing them to something, and we're trying to educate them. Then we want to think about, is this just a skill or a process, or is it a full simulation? And I always like to use this analogy. Some people think a full simulation is always the best, or everything is as real as possible. But if I'm no good at batting and I play baseball, making me play a full baseball game every time is not going to make me better at batting. So instead, I should maybe just go to a batting cage, or I'll have someone pitch to me 30 times in a row. And that's focusing on my skill rather than doing a full simulation, which would be the most real, but maybe not the best for learning. And then we want to think about those objectives. And of course, those are just individual things we want the students to kind of conquer, accomplish, or deal with before, after, or during the simulation. And then it's always good to think about, what are they going to walk away with? What's in their luggage when they leave that simulation? Again, just kind of tackling some misconceptions. Most people often think of a simulation as a surprise, and that's the best way to do simulations. That could certainly be true for cardiac arrest, which is always a surprise for us. And so maybe a simulation that's out of the blue that just says, hey, we're going to do cardiac arrest, and the students don't know about it, but they should all be trained. That could be good. But let's take an example where I think preparation is the most important. So a simulation we do with our students in their second semester, essentially, an athlete, a high school athlete, runs a track meet, has a little bit of foot pain during the meet, but it's not severe. After the meet, they don't say anything to the AT because they have a trip with their family. They're going to drive in the car and go camping. And so they go on this road trip, and about 2 hours into it, they actually can't walk now. It's so painful to walk. They don't know what to do. So they call their AT and they say, what do I do? What's wrong with me? Can you refer me, or how should I take care of myself? And, most of us can think of the idea, if we didn't do any preparation, we're just, what are the students going to walk away with when this is over? That they can't figure this situation out. And if that's what we're trying to teach, okay, but not very meaningful to be like, guess what? You don't know what you're doing. But if we took the time to prepare them, and gave them some skills, now we get to see what they're like once they do have an education and a background, and once they are a healthcare provider. So here's what we did in this situation before they got this phone call. We basically gave them 3 articles to read. You can see one is Liz Frank, one's a metatarsal fracture, it includes stress fractures, and one's plantar fasciitis. And while they're reading those articles, they had to answer these questions. And there was 4 questions in each section. So you can read that. But, what are your 4 top history questions for this injury? What's the 4 most common mechanisms of injury? What are 4 physical exam findings? And so they filled out this worksheet. And so they had that when they had the phone call, or could not have it. That was up to them. And then we had a discussion on, how do you, when you're done talking to a patient, how do you refer them on? How do you tell them what to look out for? How do you, tell them how to self-care? And then, of course, we talked about HIPAA and other considerations. And so if my goal in this situation was learning and the opportunity to practice being a healthcare provider, which one accomplished this goal? Certainly, I think preparing them and giving them some background information made them more prepared and actually helped them learn rather than just giving them a surprise. So again, prepare them, and then they might walk away with some of your goals. So they all walked away with a differential diagnosis of a foot injury. They understood 3 common foot pathologies. They could recognize the need for emergent care, appropriately referred for care, and they understood and considered the priorities of the patient. Can she hike? Can she not hike? Under what circumstances? And this models really this prism of clinical competence where, we gave them facts, we allowed them to kind of interpret and understand those facts. And then they had to show and demonstrate that learning through this experience. And so one sim took them all the way through this entire thing of demonstrating clinical competence, which isn't always the goal, but I think mostly is a good goal for us. And then we want to pre-brief the students. We want them to know what to expect. We don't have to tell them the situation, although sometimes that's good too. But so, for instance, we just want to reduce this extra cognitive load. They are already nervous. They're already, trying to figure things out. So unless we're testing them on equipment, let them see the equipment first, show them how to use the equipment. Let's remove that stress. Most of the time, learning how to use equipment is not part of what we're trying to do. Make sure you explain that it's safe for them, it's safe for the patient, you're not gonna let anything bad happen. Also that the experience is safe, that it's okay to fail, they can try something that's just way out there, you know, and they can do whatever they need to because they're practicing being a healthcare provider, which is the next one. Make sure the student knows that they are a healthcare provider. They can't at the end of the simulation say, oh, well, I didn't know I should do that, I'm just a student. You are a healthcare provider in this situation, and you make whatever choice that is. This is your time to practice who you want to be in the future. Make sure the time's clear. You know, is this 10 minutes, 12 minutes? How are we going to stop and end? Make them aware of the fiction contract. This basically says you and I know that it's not real, but we've done everything we can to make it as real as possible. And we're both going to continue down that path, making it as real as possible. So we just agree. Again, a student can't say, I did poorly because I knew it wasn't a real arm. No, we all agree we're doing our best here. And then make sure you have adequate scene information. So like this photo is one of our cervical spine simulations. It's a photo we show before they assist this patient. So give them a photo, show them a video, make sure there's a written description. And then sometimes we share the outcomes and objectives. Sometimes we want them to know, we want you to do these things by the end. And so consider whether that's good or bad, depending on your situation. And then finally, just make sure you've kind of gone through, you know, how's this going to run? How's it going to stop? How's it going to start? And what those kinds of factors are. As Hannah mentioned in the beginning, a couple of times, you're the facilitator, you know, so just make sure that someone, if it's not you, someone is trained who is available and ready to intervene. This can be very emotional for students, very stressful, also sometimes for your standardized patients. So just someone who has knowledge and experience. And I also recommend if you have a procedure that has any chance of a safety consideration, that you have a safety monitor that's always available. So I have the director of the program always on hand, just in his office, but on hand if we're dealing with something that could somehow be unsafe, and anyone can go to him at any time if they feel something's unsafe. And then again, as Hannah mentioned, the most important aspect, so is this debrief. That's both true in the research, but also you may agree with this, that it's the most important thing. So we gave students this experience. You know, they experimented and they got this concrete experience when we're looking at this wheel. And then we want them to reflect on that experience and be able to then conceptualize, well, how would they change their behavior? What would they do moving forward? So if we don't do this debrief, we only get to the top half of that wheel here. We just experiment and have an experience, but they don't reflect and walk away with how to change. So we want to make sure this debrief captures all of that. And Naxal provides numerous styles and formats for a debrief. I don't know, there's like 12 at least. So look at those different styles, use some of that. Your feedback, also consider when that happens. It could be during the simulation. Some simulations, it's anytime you have a question, stop and let's answer it. Sometimes it's just at the end. Sometimes it's much, much later. Is your simulation for an individual, a group? Do you want them to reflect as a group? Or individually? I often have them do a journal entry or, you know, write about it. And then, you know, we use video as a rubric that they fill out, you fill out, written presentation. So your debrief can take many styles and your feedback, but they really need to be well considered as it is the most important to the student. And this is where most of the learning occurs. It's really important to stress to them and to teach them, you know, you're a peer and you're a peer healthcare provider in this situation, and you're in a room of, let's say, 20 others who did the same simulation. And now you talk to other healthcare providers and ask them questions. What did you choose to do? I chose to do this. Do you think that was good or bad? You know, this was a horrible experience for me. I feel like I did a bad job, but they're sharing as healthcare providers what they did and how to improve. And that's really important. We guide them through that process and help them with that. Hannah's going to wrap everything up in case I left something out or she thinks something important to put in here. So she's going to go back into this slide.
Thanks, Josh. So just to summarize that, it's really important for you as educators to come into the simulation with a goal in mind for your students, and to do all of that preparation in advance. In the end, it will turn out with a much more beneficial learning experience for the students. I do just want to add one thing on your part as acting as facilitator. It's really important that students understand, like Josh said, that they are in a position where it's safe for them to fail, so that kind of eases some of their nerves, and they know that they're in a safe learning environment, and that you as a facilitator will intervene if they do something that is dangerous for the patient. So that will kind of take some of the stress off of them.
So some other aspects to consider is evaluation and grading. So, how do we evaluate them? How do they evaluate themselves? And how do we consider grading in a simulation? So we certainly want them to self-evaluate. One thing I usually do, there's a nice article on reflective practice, and it basically has them say, what situation did you encounter? How did it make you feel? What happened in that? How do you make sense of all the things that happened? And then you want to, review and think about it. And then how will that change your practice? So I don't do this every time, but the debrief often looks like this. And I also have them self-reflect on this before coming to the debrief. Again, not every time, but it's a nice tool. And then, how do we evaluate them? How do we grade a simulation? And I think there's lots of things to consider here. I've tried scores and grades and all kinds of things. And what I've come to is most students want to score. They want to know where they fell on this continuum, from 0 to 100, let's say, but they don't want a grade because, they're not trying to get a grade. They're just trying this experience. So consider a score, but maybe no grade. And of course, all these can be combined as I go through this. Consider a pass-fail. So maybe as long as they hit 70%, let's say, they pass, regardless of what happened. Some students also like a critical fail. So if it's CPR and it took you more than 15 seconds, let's say, to feel for a pulse and breathing, critical fail, you have to repeat the simulation, or you just failed it, whatever it is. Something to consider depending on the type of simulation. I started doing a no penalty retake. So if someone gets a lower score or just doesn't do as good as they want, or they failed, that we'll recreate the simulation for them. Now, sometimes these simulations take an enormous amount of time, effort, money, coordination, and we can do that. But sometimes we'll tell them, it'll be on a different level. We'll repeat it, but maybe it's just, another student or someone else, just to give them that experience. And then I would consider too that, you either reduce your feedback, especially in the debrief. Your goal is to facilitate them having a conversation. And so how do we reduce that proctor feedback? There's certainly a time to say this skill went good, this skill went bad, and to let them know that. But we really want them to start thinking, I'm a healthcare provider. Did I do good enough? And can I rely on a peer to evaluate how I did? And then finally, consider delayed feedback. We use this a lot. Just like you and I, if we provide healthcare for someone and we didn't think it went well or something did go wrong, we go home and we stew on it all night. We worry about it. We fret about it. And we have to learn to cope with how that feels. And same thing when we do something really well, we have to decide, did we do good? Because sometimes the patient doesn't tell us. So we want the students to learn how to adapt to that same everyday work life. Don't give them immediate feedback and pat them on the back right away. It also takes away their own intellectual process of thinking through how they did. If you immediately said you did good or bad, now they don't think about it. So we usually don't give feedback till a day later, at least, sometimes longer. Oh, sorry. Let's see if that'll go away. Okay.
So then it's time for you to do the fun part, and you get to design your simulation encounter. So we feel there's 4 important steps in you designing your own simulation encounter for your students. First, you want to determine if there's evidence to support the need for doing a simulation encounter, as opposed to these students learning these skills or encountering this patient live at their clinical site. So we'll do a lot of simulations that are a little bit more general medical related or more emergency related, because those are what we would say high risk but low incidence conditions. Or you might want to consider a student is going, or your students are going out to this particular area, and you want them to be prepared to interact with this certain type of patients or this certain condition that happens often with these patients. So you may prepare them with materials and then have them do a simulation to help prepare them for going into those live patients there. Once you've decided if it's important to have this type of simulation, you want to construct your objectives. As Josh mentioned, those objectives could be shared with the students, or perhaps they're just for you to measure. But I find it's helpful for the students to be able to see, okay, by the time I finish this simulation, these are the skills that I should have. Then it's time to structure your simulation format. So come up with the purpose of this simulation. Why are you having your students do this simulation? What learning theory is your encounter based on? If you want to consider different learning theories, how is this helping your learners? Do you want them to be more confident in a certain area? Do you want to build their skill in a certain area? Do you want to build their interprofessional communication skills? Kind of what's your purpose behind that? And then what type of simulation will you use? So will you have physical fidelity? Will you incorporate specific equipment? Will you have it be a case-based learning? Will you have it be, as Josh mentioned, like a phone call? So you have someone who's trained as a standardized patient to just call your students and act as a patient over the phone. So determine what you need for each simulation, and then you get to design your own case. So in terms of preparing to design your case and implement your case, we wanted to kind of walk you through some of the practical implementation that we've found useful. So when you're writing your case, it's important for you to think about what equipment and resources you will need, because you want to have that all in that area for the learners, so they're not wasting time running back and grabbing an AED trainer or something like that. So identify the equipment and resources you need and write those down on your template. After this webinar, you'll be receiving, it's just a generic template for a standardized patient training. I've found that it's helpful to use that so that you write down all of the information about the simulation and the information that the standardized patient needs to know. There's a lot of different templates out there that you can use, but if you're starting from square one, you might consider that one. If you are using standardized patients for this simulation, you'll then need to recruit and hire those standardized patients. For some people, it's hard to locate standardized patients in your area. Maybe you're in a little bit more of a rural area, or you're a smaller college. We've found it helpful to reach out to our nursing program and ask what standardized patients they're utilizing and if they're willing to be recruited by us. You could also consider if you have a medical program close to you or a physician's assistant close to you. Most of them use standardized patients as well, and so you may be able to find them that way. Other colleges will simply put out an ad for hiring standardized patients and give a description of what you're looking for with them. You also may have to locate facilitators. If you're doing a larger simulation and you need multiple facilitators, you may have to find either coworkers to help facilitate or outside health professionals to help facilitate. Also, again, if you're hiring standardized patients and facilitators, it's important that you train them. So that case template that I mentioned that we would be sending to you is what you'll want to use to train your standardized patients. So you'll be writing out all of the information of that standardized patient so that when the standardized patient has that encounter with the student, they know everything about their condition, about their personal life, so they can answer the questions that the students will ask them. And then you'll want to train your facilitators as well. We encourage both standardized patients and facilitators being aware of a safe word or a safe phrase. Josh likes to use the time in, time out method, or you could train them on a specific phrase that if the standardized patient says it at any time, then the simulation will end. That one's really helpful for if you have a little bit more of an invasive technique or something that's a little bit more close to home for that standardized patient if they're portraying an emotional case. that can be helpful just to ensure safety of both the students and your standardized patients. And then timeline is really important as well for you to determine. If you don't set a time for your students for how long this encounter should take, they may take much longer and you'll run out of time for all the students to get a chance to have this encounter. So it's important for you to establish that timeline. Also, if you have standardized patients, you want to have them come in advance so that they can get familiar with the area, ask any last questions that they have. And then also a timeline for debriefing. If you're going to be bringing the standardized patients back to join in the debriefing session, what the timeline is for that.
And so Hannah and I thought, we just run through some simulations we've done to give you some ideas or things that you could do. So some obvious ones, right? Like a splenic rupture that of course could be traumatic as well as medical, but more of a medical diagnosis, but could be HIT. Emergency, course cardiac arrest we discussed. An orthopedic exam. So this might be more of a skill-based one, doing an ACL tear and doing some special tests to figure that out. Breaking bad news. So we've had ones where the AT or the healthcare provider has to speak to, a parent for a high school student, or has to speak to a coach that the rehab plan they made isn't on time and the athlete's not getting better the way they thought. Or telling the patient, they tested positive for a banned substance, or they, have a degenerative disc disorder or something. So we've done those, how that works. That's a great thing to give students practice, is breaking bad news. Interprofessional education. So we also have like a video of different healthcare providers and how they interact with a concussion, from an audiologist to speech language pathologist to a PT to an AT, and everyone's role in that, and they can kind of interact with that. And so they see everyone's role in a entire concussion rehab plan. Of course, another one, a different way to think about a simulation. We do a simulation where it's like your monthly athletic trainer meeting, and someone brings up a topic about a transgender athlete in track, and another athlete doesn't like this idea, or feels like it's, unfair that this track athlete gets to be in track. And so as ATs, they all sit around and say, well, what are we going to do? How do we address both of these athletes? How do we deal with this? So not what you'd normally think of as a simulation, but they get to be an employee discussing a problem with other employees and come up with a solution. Professional ethics, we usually, I often try to combine simulations. So like with this one, there's 4 tape skills they have to do, ankle stabilization, McConnell tape, a thumb spike or whatever. And during that, each athlete brings up a different topic. One asks them to go out for a beer later. One swears all the time and kind of says inappropriate things. Another person is gossiping about another AT who they think, is not very professional and they don't like. And so the AT doing the taping has to both tape and then figure out, how do I address this situation? And then it's always good, I think, to do common or things people will see all the time, like an ankle sprain. We do a nice one with tennis. You have a 5-minute medical timeout, and they have 5 minutes, and half the group sees an athlete who has like a grade 1, and the other half sees a tennis athlete who has like it's pretty serious grade 2, where they shouldn't go back in. And they have 5 minutes to kind of evaluate, tape it if they can go back in and make a decision. And you're going to see that a lot. So why not make them do something they do all the time? So you probably didn't get good at evaluating an ankle until you did 100 of them. Let's give them the first 50 with us, and then the next 50, it'll be a lot faster. And then of course we talked about skill or procedural simulations. We do one where there's a situation written on a piece of paper. What's the special test? Is it conclusive? What should you refer them to after this? And they go through and do like 6 different ones on 6 different patients very quickly. So some ideas just of what we've done. Some tips for success real quick. I would plan on 10 to 40 hours the first time you create a simulation. That's to write it, to kind of be a part of it, to get everything off the ground. If you have more people, that could take less time, but I've never done one in less than 10 hours to create it and everything. Get ideas from students, look at your outcomes, the standards, anything you have, peers, things that have come up from clinical sites. Your students aren't prepared for this. So make a simulation based on that. I collaborate with students or with other faculty all the time, trying to get ideas and figure out what we can do. So don't shy away from collaboration. It's a big lift to do on your own. I really recommend trying it at least once, even if it's just a basic walkthrough. We created an abdominal organ injury one, and the patient was lying down on their side, unconscious. And when I thought of it in my mind, I just thought they were going to evaluate, the organ because the patient wakes up right away. But I realized, well, they're unconscious, they're lying on their side, I should probably do a spine evaluation as well. And I didn't think of that when it was just in my mind. So try it once. You'll always be surprised at what comes up. And then make sure you provide the students the space to be healthcare providers. Let them make mistakes, unless it's unsafe, don't help them out. This is their moment to figure out what's going on. And just, give them the space to be a healthcare provider. And I also give them that space if they come to me and say something with really great logic about the choice they made. Hey, you're a healthcare provider. That's a good choice. I didn't choose that, but you're not wrong. So, that's your choice. Things will rarely be how you imagined. Always surprises come up. I recommend rarely using people in the student's immediate circle unless it's kind of just some, minimal practice. But if you use other students or if you use the instructors they see every day, it just feels different. You can use other professionals. So I use other ATs in the building, but I'm not going to use people they see every day because that just doesn't have the same heightened sense. So get some standardized patients, use other ATs or professionals. I already mentioned that one. And then, of course, make a schedule and a timeline. There are so many boxes to tick as you do this. So definitely make a schedule and a timeline.
So we do have an activity for everyone to do, but we thought it might be best if there are some burning questions about what we've talked about, that we field those first before we get into our activity. So Ollie, I don't know if there have been any questions in the Q&A that we can answer.
There hasn't been anything yet, but I have just sent a nudge out to the group on the chat. I'm happy to ask a question because I found a lot of that kind of new information to myself, and certainly some areas I hadn't heard of, or at least I haven't experienced as of yet. And I know, Josh, you talked about kind of student role playing and making sure that you cue the students to kind of make sure that they evoke that emotion that's often experienced in some of the real life situations. I was just wondering if you could provide a bit more information about maybe some of the cueing and briefing that you do with the students prior to them being a part of the simulation.
Yeah,
so that was,
go ahead.
Yeah, that was something that I mentioned, but I think Josh probably has some perspectives on it as well. For me, when we have like an emergency case that we're having the students interact with, I've found it helpful for them to kind of put themselves in that position first and kind of view it as like this is someone's child or parent or family member. And so I'll have them like read an article, or you could have them like watch a video about this case and how it went badly, and then get them to think like, I don't want that to happen to me and my patient. So evoking that emotion is helpful to kind of get them in that setting. Go ahead, Josh.
Yeah, I was just going to follow up on that too with it is useful sometimes to be purposely deceitful, but not to be unkind. So we do a simulation where we have an athlete with an elbow dislocation, and we prepare them for that. But a coach comes in and actually tries to get confidential HIPAA information from them, and they don't know that that's the point of the simulation, is how, amenable are they to giving the coach secret information. So as far as prepping them, whether that's emotional or intellectual or whatnot, again, that's part of that purposefulness. If I told them that it was going to be HIPAA, everyone would be like, well, I'm just not going to say anything. And then we'd have to talk about, well, we can say some things. But this way, it's kind of purposefully not preparing them on one topic, but preparing them on another. And that one for us is one of the most emotional people. They love it. I can't believe it. Every year students ask us to do it again. And I think, oh, that's unfair. They're like, no, like I learned so much because I walked into this huge hole. I told them all her psychological problems and all her health problems. And and it's really emotional that way. So anyway, it's kind of the same, but a little bit different as far as preparation generally. So, it's very strategic what we prepare them for.
Yeah, thank you. And apologies, Hannah, for mistaking who presented that content.
It's
We've got
easy
some
to
questions.
get mixed up.
Yeah, we've had some questions in the chat, so thank you. The first one's from Joseph. So thank you, Joseph, for your question. The question is, what are your thoughts to have preceptors be integrated into these simulations with the students? Do you feel there is a benefit to having them do the simulations together, separately, or both?
Go ahead, Hannah, you go first.
So actually, my dissertation research is on simulation, and I presented some of my results at a conference recently, and some of our own preceptors actually came up to me after, and they were like, when you do this simulation again next year, can we come? And I hadn't thought about that before. We kind of gave an invitation to them. If you want to come practice, you can certainly come practice. But I think, depending on what situation it is that you're practicing, that could be helpful. Either like they could be the proctors, or they could be people in the simulation. If you're doing a mass simulation, I think when people think of simulations, they always think of like this huge all day long event with multiple people. But it could be very simple, like as a phone call or just practicing a skill over and over. So I think it's up to you in terms of what you're implementing, but I would bet a lot of your preceptors would be interested. It's a good like annual in-service kind of thing for them.
Yeah, we'll use preceptors as part of the simulation, mostly only if we have no other choice, or when it's really good that the preceptor has some background. So, only, well, I don't know if this is true, but mostly another AT will know what a special test should feel like. So we use the ATs as a preceptor and the patient, because they really know how the handholds feel, what that feels like when you pull. So if it's something they really know about, then we have the preceptor also be that patient, because it's a certain feedback you can't get from, standing there watching. So that's mostly the only time. But as Hannah said too, we have certainly involved them in it when it's, you have to speak to, we basically do one where you're the student AT, and then there's a head AT, and this head AT is busy and says, go get a history from that patient, don't touch them, come back and tell me what you found out. And it's a telephone game. How well did you relate that condition? And then the AT gets involved and knows. So we certainly do, but it's always strategic. It's usually not just like, that's all I have.
Cool, thank you. And we have a question from Sarah in here that says, I understand the notion behind reviewing equipment prior to the encounters. It does sound important, but how do you combat students making assumptions about the case once they've reviewed the equipment?
I guess I'll start since I said that one. Yeah. So so one of two, a couple of things. One, you can disguise it somewhere else in the curriculum, right? So it happened 3 weeks ago in another class, and you've coordinated that they've looked at it. So now it's not an issue anymore. Another one is you can give them, so when we do that telephone simulation, we tell them to review cardiac arrest because we're going to do it later. But we don't tell them before we do the surprise cardiac arrest. But on that preparation, one of the things they prepare for is cardiac arrest. So they look at the AED and prepare on a totally different day, not knowing it'll never come up until much later. And then depending on the sim, you can have them review it. I am always surprised. It's just kind of like, for you, if you knew you were going to use a modality, you've seen the equipment before, you've done it 100 times, but it's still okay that you're going to do it when you go in. It's still good to practice and get good at it. So does it really matter that they know what they're going to do? They still have to do a good job, and they have to do it right, even if they almost know it, almost every component. So that'd be my 3 thoughts on that.
Yeah, and I'll add to that. There's some benefit to having the simulation be a complete surprise, like Josh said, if the students have prepared in some way. But there's also a benefit to just getting them in there and practicing. Let's say it is with a standardized patient that they don't know, so they can feel like they are in the actual encounter, even though they already know what that outcome is going to be, what skills they're supposed to perform, or even what the diagnosis is. perhaps your goal is that interpersonal communication, and so they can learn that they're not so much testing their skill. So I think it would depend on what your purpose is for that simulation.
Good question. Yeah.
Yeah, we have another question from Michael. So, although considered important, do you think that video recording equipment is worth the financial expense and time commitment for the debriefing process to maximize learning outcomes?
What do you think, Hannah?
I might need some more clarification. Are you suggesting doing like the students submitting a video of their reflection and to save time?
Well, I think he might be referring to, should we videotape every sim encounter?
Oh,
And
gotcha.
is that really worth it? And I can say for the first couple of years, I did videotape everything. And I'm not sure that it was always useful for the students. They didn't often rewatch it. Sometimes they did. Sometimes I did. Sometimes they didn't. So again, I would say it's just another strategic tool. Most of the time we don't videotape these days, depending on the encounter, for lots of reasons. Again, just think about it. Is it something you really want to watch? Is there a goal for videotaping it? The only time, Hannah and I were just talking about this before we got on, the one major consideration is if these are students, do you want to tape something and just, put it away like no one knows it's a secret, just in case someone says something went wrong or you have to verify something? So that's a consideration. But we used to get cameras and all that stuff, but now we just use an iPad or someone's phone and upload it, or Zoom. For our HIPAA one, we use a Zoom computer just sitting in the room. So I would say most of the time we don't videotape as long as it's not really a part of the experience that we're going to review.
Right. I'll say if it's a summative type of encounter, so this is a testing situation, it might be like safer for you to record it, just again, like Josh said, in case a student is like, no, I definitely did that. Like, because if it's something that affects their grade, they might be a little bit more defensive. So then you have, okay, well, we did record it, we can pull it back up and watch it. But otherwise, yeah, I don't think it would be necessarily worth it to record every encounter.
Cool, thank you. And then we've got another question from Joseph. Thank you again. What are your thoughts about having distractors during the simulation, i.e. crowd noise, parent running onto the field?
Go ahead. You want me to do it, Josh?
It doesn't matter. Yeah, I'm sure we'll both say something. So I think they're good and they're important. Again, going back to that batting analogy, depending on where they are in their learning, if they can't bat, then no, take away the distractions. If they're good at batting and we're ready to see them play a game or the point is, can you handle distractions? Then absolutely. And we, sometimes that can be a distracting injury as well, or something else, but we definitely use distractors depending on, the level of the student and the point of the simulation. Absolutely.
Yeah, I was going to say it definitely depends on your purpose. But I was just talking about this with another faculty member a few weeks ago about doing our final evaluations for our second year students, having them perform that evaluation at football practice with athletes and coaches running around and doing their own thing anyway. So then they have, you're not having to hire all of those people to portray those athletes. You have it, if they'll let you do it up there, you'll have that natural distraction, because when we're evaluating an athlete on the sideline, there's other people and noises and people coming up and asking for a Band-Aid and all that. So it's good for them to not just be in that white room with complete silence.
Yeah, and I'll reiterate what Hannah said here that we didn't bring up is that in situ experience where you that sometimes this is enough of a distractor, even if the athletes aren't there, but you actually go to the field for the students, all kinds of things they never thought of come up. We did a baseball one where someone in the outfield got injured. Well, guess what? That's a couple 100 feet you got to run before you even see the person. And that's something we didn't even think of at first. And so being in the actual situation brings up all kinds of things that nobody thought of. And then, of course, as I love Hannah's suggestion, can you, even during a practice, just be on a sideline with all the other distractions? Because the real environment, when you can do it, again, knowing if your students are at that right level, is over. I mean, that's enough of a distraction just being on the actual field sometimes. So strategic.
Will you prompt the students that there's going to be a distractor coming? So will that be a brief that you'll provide them? Because I know sometimes if you tell them that there's going to be a distractor and then there isn't, that itself could be a distractor, and it's so they kind of prepare for something to happen and then it doesn't, they could throw them off. But is that something you'll brief them on prior to the simulation occurring?
I think it's important for them to understand, okay, we're going to be doing this. You're going to be doing an evaluation on the football field during football practice. So it's not going to be complete silence. You're not going to be able to have time with your thoughts. You might get interrupted by the noise.
Yeah, cool. I'm aware that we're getting close to that hour mark. So I know Hannah and Josh, there's maybe something else that you wanted to add. If there's anything that you wanted to kind of close off with before we get done here.
Yeah, we do just have one more thing. We want to get our participants kind of thinking about how they might design a simulation. And Josh is going to pull up.
Am I sharing? I'm not sharing. Let me go back to sharing.
You're not sharing, no.
I pulled it up, but it wasn't sharing. Yeah, sorry. All right, share screen. Okay.
So we want you to get thinking about designing your own simulation. I actually was kind of looking through the chat to see who was on today, and I saw on a lot of your titles that you are directors of simulation. So this might be old hat for you, or you might be here to learn some new tips. But if it is your first time, you might be a little bit overwhelmed. So we wanted to give you kind of this is also perhaps a little bit of a template here that you can work from, but we want you to think about, if you see this picture, or if you're thinking about showing this picture to your learners, what type of simulation do you want to do based on this picture? What topic would you consider this simulation being? What level of learners do you think this would be appropriate for? What might your outcomes be, like your goals for your learners? What format will you use for simulation? Will this be a standardized patient encounter? Will this be a phone call from a coach? And then what resources and materials might you need? I think perhaps don't take the full 5 minutes because we are getting close to time and this might spur on some more questions, but just take a couple minutes to consider, this is the image that you want to use to show your students what the encounter is going to be. What would your purpose and topic be for it? I think, Ollie, if I'm right, we can give microphone access for people to share, a couple of people to share.
I believe so, yes. I think people need to raise their hand.
We can do that, yeah. People need to, if they press raise hand, we can then give them the mic, which other Ollie, you should be able to control as well, mate.
Yep, I can see that, yeah.
All right, let's see if anyone is willing to share their ideas.
So I mean, I guess I can get it started. I'll take the reins. I think using that picture would be really good. Obviously, I think what jumps to my mind and something that we've never really, well, we don't really incorporate or haven't incorporated simulations within our formal teaching too much, but certainly looking at that, it would be kind of the management of head injuries, on-field head injuries. And I think for us, it would be really good for our kind of final year students or final year master students or undergraduate students to be assessed on that. I really like the idea of using standardized patients. I think that's mainly because I've never encountered them before. And I think it would be really fun. I guess with those sorts of things, whether or not they're conscious or unconscious can play a big part in how well kind of educated and trained they need to be. And so, yeah, I think that would be my kind of approach to it, or at least something that I'd like to try out. Again, that's probably quite obvious and quite straightforward. Maybe other people have some more rogue or things that are slightly off center with that, but yeah.
Yeah, no, that's good.
And I did see that Sarah in the chat put, I would likely utilize it as an acute care or emergency, like immediate response scenario with first year Masters of Athletic Training students.
Mm-hmm. And Robert has raised his hand, so I'm going to test my admin skills here and see if I can allow him to talk. So Robert, I should allow you to talk now. There you go.
Yeah, hopefully you've got me now.
There we go. Yep.
Yeah, perfect. Yeah, I think my thoughts were similar to Ollie's in terms of sort of that purpose being around head injuries, buttocks, bleeds, concussions, and sort of around that, and sort of to our final year students. But I also quite liked what Josh and Hannah said about adding in possibly that rogue element of the coach who comes in and goes, oh, just put them back in play as well, just as sort of to completely throw them off a little bit, but also once again gives them that Wolby HIPAA element as well.
Nice.
Yeah, he just needs a Band-Aid. Send him back in.
Yeah, that's nice. Yeah, how do you have that discussion? That's good. Yeah.
Yeah, so there's a lot of,
go ahead. No, go ahead.
There's a lot of different ways that you could go with just this one picture. And so I think the obvious one is, well, there's a lot of bleeding, so it needs to be an emergency care, but you could add some of those extra elements all within that same simulation.
Yeah, and I think a nice distractor here is not that I would do cardiac arrest with this one, but how many people would go to the head injury and not even see if they have a pulse and breathing?
Right.
Because that would, most people are going to see blood and be like, oh, that's what I need to do. I went way off. I'll share mine because I tried to do something very different, and we'll see what other people said. So I decided to make it up with you that I would make the AT students develop a kind of education program about how, thinking of this recent situation, what the other athletes should do on the field. Should they surround to give privacy? Should they help? Should they not touch the patient? If they do, should they hold C-spine? So could they get together and create an education program for how to handle a situation like this in the future? It may be a bad idea, but I was like, oh, that's kind of interesting. Do something different, you know. Another one, Ollie?
Yeah, we got Matt Lewis who's raised his hand. So Matt, I will allow you to talk and you can jump on.
Thanks, Ollie. I appreciate it. Hannah and Josh, thanks so much for sharing this content. This is really helpful, and I think something that's really important to a lot of our programs. But I think one of the things that we've done with more advanced students is adding a second patient to a simulation. So having that image there of the bleed from the head wound, and you sort of talked about, Josh, within that same patient, maybe adding a cardiac complication, but adding a second victim, if the scenario was a head-on collision on the soccer field or something like that, to see how they think critically in the moment, because the bleed may be the more minor of the two, but it's the more obvious of the two, depending on what injury you assign to the other athlete or patient involved in the situation. So I think obviously that's one of those where they already have to be able to hit before you complicate it too much, like you talked about. And then I think taking the video a step farther to give them a video clip so they can see the mechanism in real time. Because when we first started doing this, we often went to the side of, let's make this a complete surprise and not give them any background information. That's not wise. We learned from our mistake there, and that we need to give them some background so they can perform at their best and reduce some of that stress. And so a video clip, if it's appropriate, where there's a mechanism, gives them an understanding almost like they were on the sideline seeing this happen in real time. So Thank you.
Yeah, excellent comment. Yeah.
Yeah, and then that gets the emotional aspect as well. So they see it and they're like, oh no. And so they know immediately that they need to react.
Yeah, and I love the two athletes. Yeah, we're going to try that for our acute care final. We're doing a simulation. They don't know yet, but we are going to have 2 athletes to see how that works out. Yeah.
Thank you very much, Matt. It seems like that is all of the hands raised at the moment. Yeah, Hannah, Josh, was there anything you wanted to add before I close the session out?
We do have a reference slide if participants want to check out some of these references. And if there's any other questions following that, kind of getting you to think about designing your own simulation. I'm not sure how much time we have, Ollie, but if you want to, if anyone else has any burning questions.
I'm happy to field some questions if anything comes in. I think Shannon's asked one in the chat about are there any kind of repository for sample case studies or video clips?
Yeah, I wish there was. Josh and I have actually talked about kind of creating essentially a book of simulations. But to my knowledge, there isn't anything out there.
And there is kind of one, but not related to athletic training. And so it's more like a nursing one that you can pay to be a part of, but having some kind of repository would be awesome. And so, yeah, that's why Hannah and I are going to try to create like a bunch of cases, but also, I mean, we've already created them, so why not put them together? And why not have, you know, all of your expertise looking at those two and saying this is a great idea, or I think you should change this, and just having that, you know, professional exchange that we're asking our students to have with these simulations. So hopefully soon we'll start something like that.
And we've just got one more attendee that's raised their hand. So Colm, I'll just allow you to talk, and we'll keep that as our final kind of question or comment. So Colm, you should be able to grab the mic now. No, I think you might need to unmute yourself. I can ask you to do that if that prompts something. Otherwise, no. All right, looks like we've lost Colm.
Can you hear me?
Yeah,
Oh,
I can
there we
hear you
go.
now. There we go. Yeah.
Not used to using Zoom, mostly use Teams. So with respect to repositories, I'm lucky enough to be still in practice life. And from time to time, I'll come across interesting patients where I'll follow the journey through, and I'll ask if I can use the scans and documentation to present to students. So we do case-based simulations in class where we'll do a think, pair, and share exercise. So I'll give them a copy of the case history. I'll ask them to read through it and think about, start working out what their differential diagnosis might be, what special tests they want to undertake to rule in or rule out certain types of conditions. And then we'll pair up and talk about what it is that we've kind of found in our case histories and learn from each other's experience, and then into groups. As a group, then we'll discuss it, and we'll get the groups to present various different elements of the history, from the case summation to the differential diagnosis and then the treatment and management plan. And then we'll work through the scans, and I'll discuss with them how the scenario is actually played out in real life, what's actually happened, how has it been managed, what's worked, what hasn't worked. And the students really find these interesting because they're real life scenarios. They get to see somebody's scan, they get to see a disc which has protruded and is now kind of pressing on the exiting nerve roots. And subsequently, we've had a couple of fractures where we've had to have stabilization as a result. And most recently, the one I had was a stress fracture in an osteoporotic female, where we got to discuss the FRAX tool and use the FRAX tool, and then basically look at osteoporosis and look at it as a springboard to learn more about kind of, particularly in women's health, where individuals have radical hysterectomies very early in life and HRT cover up afterwards, and then basically go on to develop osteoporotic risk factors. So I think that's kind of ideally kind of a good learning opportunity if you're still in practice life and you can use those case histories and get permission from patients to do that.
Yeah, that's excellent.
Yeah. A lot of the like case-based learning that I write comes from previous athletes of mine, because I know the case really well since I was the athletic trainer taking care of them. So it's easier than having to make everything up because I just am able to remember it.
Yeah, and we'll try to do that same thing. Awesome, Colm. We'll try to get we'll do real cases, because they're often stranger than the ones you make up. And then also when you don't have the students saying, well, that's weird, like, no, that one's real, that actually happened. So
Actually true.
I think it's a good backup to use real things if you have them, and we certainly try to. That sounds like a great experience though.
Yes, thank you, Colm. Appreciate that last input. So yeah, I think that sounds like a good place to leave it. And once again, just want to thank you, Hannah and Josh, for presenting today. I think certainly personally found it extremely interesting, something that we probably don't do enough of, which hopefully we can now integrate into our practice here in London. So thank you very much. I just want to highlight everyone to the questionnaire at the end that will be sent out. So please do provide us feedback. It will be excellent to hear from you as an audience to how this ran. And then also, I know Brian put it in the chat, but if anyone's interested, the World Federations Congress is in Israel this year. The registration link will go live next week, so please do aware of that. And if your institution wants to become a member of the World Federation, you can find the information on their website there, but we will hold member webinars in the future as well. So this one's been publicized out to everyone, but in the future there'll be some member kind of specific ones too. So I think with that being said, just again, thank you very much, Hannah and Josh. Learned a lot from you both, so appreciate your time and hope everyone has a good rest of the day if you have a long time remaining. And yeah, take care everyone. Thank you.